let's talk about the airway. Inhalation is an active process. Your muscles are engaged, they're contracting, pulling out your thoracic cavity, making it bigger. That diaphragm pulls down, creating that negative pressure. So that negative pressure is basically just like a medical syringe. As that plunger pulls down, it's going to be pulling that air down in. So with those muscles activated, diaphragm moves down, your intercostal muscles are contracting, open up that thoracic cavity to increase the volume you can store air. Where exhalation is more of a passive process. All those muscles relax, the diaphragm goes back up to its normal curvature, and that air releases. So again, that diaphragm, just like if you're holding that syringe upside down, as you can pull that plunger, as that diaphragm comes down, it's going to be pulling air in. And a lot of people always talk about the reason why it's harder to breathe at higher elevations. So what do you think? Is it due to oxygen? Really, your oxygen deficiency isn't going to increase until you're several thousand feet in the air, much higher than there's normal inhabitants. These are people who are, mountain climbers. Once you get up there, you're having to wear a supplemental oxygen to be able to breathe. But no, it's harder to breathe at higher elevations because of the atmospheric pressure. So if you think about a lot of athletes, while they go to high elevations like Colorado Springs to do training, it's to go and strengthen up all those active process muscles, your diaphragm, building up your lungs and those intercostal muscles. Because at sea level, where you've got a lot of outside atmospheric pressure, when that diaphragm goes to pull down to create that negative pressure, you've basically got a whole CPAP machine outside of you forcing air in. So it's easier to take that breath in. Where at those high elevations, you've got this really thin, much lower pressure. So if you're sitting there trying to take a breath in, there's not as much outside force to shove that air in, because respirations are all about the equalization of forces going from higher concentration to the lower. So let's throw out a good even number. So if the outside atmospheric air is 750, as you go and create that negative pressure inside your body, you've created that negative pressure, so then inside might be 700. So 750 on the outside is going to go in towards that 700 quite easily. Well, if you're at a higher elevation, where your atmospheric pressure may only be 500, that's a lot less force. It's nearly a third less of the force to be able to push that pressure down inside into your thoracic cavity. And for all the perfusion, all the oxygenation, really the whole process of why we breathe in and out, for all that to take place, you've got to have a few things in place. One of the biggest, most important factors is those red blood cells. You've got to have that hemoglobin for the oxygen to be able to adhere to. Then you have to have enough adequate supply of oxygen to be able to adhere to those red blood cells. So at those high elevations, Mount Rainier, those big mountains and people going climbing who need that supplemental oxygen, you're getting up those high elevations and you're getting below that normal 21% atmospheric oxygen. So you're going to need that extra oxygen to support those red blood cells. And those red blood cells must be able to take on the oxygen and offload the CO2. So some conditions that can affect that is CO poisoning, as we all know. That CO has nearly 400 greater times affinity to bind to that CO. So it really likes those CO molecules, and they pretty much just beat up the O2 molecules and don't let them adhere onto the red blood cells. And you must also have good blood pressure. That's Stirling's law. The force going in is the force going out. So if you don't have good systemic volume or good pressure, it's not going to be able to circulate those cells. So you can breathe fast, and there'll be a bunch of oxygen in those lungs waiting for the blood cells to come through, because there's bad blood pressure, bad perfusion to circulate all this stuff into the alveoli. At the alveoli, you've got a couple different forms of respiration. Externally, you've got the gas exchange between the alveoli and the blood, whereas internal is the gas exchange between the blood and the cells. The way I always like to describe it is that alveoli is just kind of like a boat dock. So as the oxygen comes into that boat dock, it's waiting for the boat to come in. So here comes in the barge, hauling a bunch of CO2. That's the waste products of all the perfusion that just happened. So CO2 comes in, It dumps off a CO2, O2 hops on the barge, and it makes another round to do its deliveries. And we've always been told that the alveoli are these grape-like sac clusters. So in my younger days, which wasn't too long ago, I always thought that those grape-like sac clusters were actually like the size of grapes. But on average, the adult body has approximately 300 million alveoli. So these are microscopic things happening here. With your respirations, there's two forms of respiration called, one is aerobic respiration, the other anaerobic respiration. The big difference between the two is whether there is presence of oxygen or not. So with aerobic respiration, oxygen is present. You have a good adequate supply of oxygen. So with your oxygen, good levels of glucose, the Krebs cycle goes to work and produces high levels of ATP. So that ATP is what our body needs for its main source of energy. So with that ATP, normal Krebs cycle, lots of energy production, how we should all be functioning. And without that, with that, there's going to be just a little bit of waste of CO2 and water. So, we exhale out the CO2 and then we urinate out the water. So thinking about that, if you have a patient who's hypoxic, are they going to have much levels of energy? Or you got that hypoglycemic patient. So you take out any one of those factors in Krebs cycle, they're not going to produce that ATP. Now with anaerobic respiration, oxygen is not present, or there's just not efficient amount of oxygen. A lot less energy, so the body's going out looking for sources of energy where it doesn't have that oxygen to metabolize everything. So it's out looking and searching out and just causing mayhem within the body. So it's going to produce a lot of lactic acid, making that body very acidotic. The medulla, located in your brainstem, neurologically controls all your needs for baseline ventilation. The medulla is also known as the
Medulla Oblongata.
Your primary means of regulation of breathing. The main sensor that sends that signal to medulla oblongata of how to breathe are coming from chemoreceptors in the body, so from central and peripheral receptors. Their main job is to measure the amounts of CO2 in the body, whereas a lot of people think your primary means of wanting to breathe is from oxygen. It's actually depending on the levels of carbon dioxide within your body. So it's measuring out that pH level that's within your blood. So it's trying to preserve out that acid-base balance. So if you even think about your DKA patients who are acidotic, they're hyperventilating because they're trying to maintain and balance out their pH balance. And again, our secondary drive for regulation breathing is from hypoxia, or the levels of oxygen. With respirations and ventilations, there are some really important terms and concepts that need to be understood. First is tidal volume. Tidal volume is the amount of air that's taken in one breath. So depending on which research you read, which book, whatever, your average tidal volume is about 750 for the average size adult. But the anatomic dead space, what that is all the parts of your pulmonary system from your nose to your bronchioles that aren't doing anything about respiration. So they're not doing anything with gas exchanges. So there's just air going into those hallways, and they're not really doing anything except just occupying the space. And that all kind of ties into the Bohr equation. So basically what the Bohr equation means is if you don't have, it's the difference between your tidal volume and the anatomic dead space. So if your anatomic dead space is greater than a tidal volume, there's no air getting to your alveoli. So it's just that direct effect that you gotta have a good level of tidal volume to overcome and to be greater than anatomic dead space. So the difference between your tidal volume and your anatomic dead space is how much volume actually gets into your alveoli for gas exchange and cellular respiration. So that tidal volume has a great effect on that. So think about if you're trying to ventilate that patient and you're not getting them appropriate amounts of ventilation. That air, you may not provide them enough volume to get to their alveoli or perfuse or oxygenate all their alveoli. And with physiological dead space, that's pretty much just all your anatomic dead space, and the space to where it's getting ventilated but poorly perfused. So there's that VQ mismatch, that ventilation perfusion mismatch. So what kind of example do you think that would be? Possibly like a pulmonary embolism, to where there's ventilation going on, but there's just no perfusion getting to where it needs to be. Now, with the understanding of what tidal volume is, one of the biggest things you need to calculate for use of a vent is the minute volume, or otherwise known as your minute ventilation. So basically, this minute ventilation is for homeostasis of the amount of volume over a single minute that the body needs. Okay, so to calculate that minute ventilation, that is 120 milliliters times their ideal body weight. And referencing the ideal body weight depends on if it's male or female. So for males, 50 plus 2.3 times their height over 60 inches. So if they're 72 inches, that would be 2.3 times 12 plus 50, because you got to remember those order of operations. So a common practice for that is to take their height in inches, subtract 60, and just multiply by 2. And the reason that's a commonplace is because if you get an odd number that's single digits, when you go to adjust the ventilator, you're only allowed certain increments depending on the manufacturer of the ventilator. So that may be in increments of 10 or 20 anyways. So there's a little bit of tweaking on the numbers. So multiplying by 2 is a field commonplace acceptance. Okay, so you're going to take 120 times that ideal body weight that you calculated out, and that's going to get you your total minute volume. The physiological norm of for what is norm is 4 to 8 liters a minute. That would be anywhere from 4 to 8,000 milliliters per minute. So you take that tidal volume of 4 to 6 milliliters times your ideal body weight also. So that is how part of that calculation into the minute volume is figuring out that tidal volume. At 6 milliliters is a physiological norm depending on the body weight, because the taller you are, the more your lungs expand, the more volume that they're going to take. It doesn't matter your actual mass, how fat you get, it just depends on your overall size and your gender. Any tidal volume that's over 8 per milliliter or 8 milliliters per kilogram can cause significant issues such as barotrauma, and numerous studies are out there indicating where tidal volumes over 8 milliliters per kilogram definitely increase mortality exponentially. So now let's do a practice. So we're going to solve for tidal volume for an 80 kilogram patient, and this 80 kilogram patient, that's their ideal body weight. So let's solve, and that's going to be 6 milliliters times their ideal body weight of 80. So their tidal volume would be 480 milliliters. Now think of that tidal volume that we just calculated of 480 milliliters. So think about when you're going to ventilating that patient, that you've got this great big bag valve mask, and the common place that you'll see a lot of people do is you'll take that bag with both hands, squeeze the entire bag empty. Okay, so how much air is in that bag? If you squeeze it in the bag in its entirety, how much air are you going to deliver? Well, it depends on the manufacturer. The commonplace, such as the Atelectasis, one that is pictured here, holds about 1,500 milliliters of air. So now think about all that. So you're taking this humongous bag, you're squeezing it completely, and you're delivering over 1,500 milliliters of air. So all you're doing is you're completely over ventilating these patients if you squeeze that entire bag. They make them easier, they put a strap on it for convenience of the EMS provider, or whichever kind of medical provider is using the bag. So think about that again. Average person, 80 kilos, needs a tidal volume of roughly 500 milliliters. You give them 1,500, you're giving them 3 times the tidal volume they need. That's going to cause barotrauma, increase thoracic pressure, which is going to reduce cardiac output. So think about those overventilated lungs, and what sits right in between those lungs? The heart. What kind of patients are we generally ventilating? One's in cardiac arrest or near pending cardiac arrest. So we're going to reduce the cardiac output of these patients by overventilating them, causing gastric distension, barotrauma, and just a whole cascade of other effects. Now that we know what tidal volume is and how to calculate it, the next step is to calculate your minute volume. So how much of that tidal volume are they going to need over a minute? So to calculate that minute volume is 120 milliliters times their ideal body weight. So let's practice here. So you've got an 80 kilogram patient, their ideal body weight. It's the same one we used to come up with that tidal volume of 480 milliliters. So do the math. 80 times 120, what's going to be your minute volume? The minute volume for an 80 kilogram patient is 9,600 milliliters per minute, or otherwise that's your 9.6 liters per minute. Now, the next step of all this is we got to figure out our respiratory rates. We just don't throw numbers out there, because minute volume equals tidal volume times respiratory rate. So simple math, the respiratory rate equals the minute volume divided by the tidal volume. So what respiratory rate do you need to set at this patient who we've calculated a 480 milliliter tidal volume for? What is going to be the respiratory rate we need to set the ventilator at? 20 breaths per minute. 9,600 divided by 480 milliliters will give you that 20 breaths per minute you need to set the vent at. So if you've been around the business for a little while, you've probably seen that standard vent setting if you were working with your partner before, or even before you were a medic, or early on in your career. You saw those vent settings of 500 milliliters for tidal volume and a respiratory rate of 12, just because most people on average have a tidal volume of around 500 milliliters, and people on average breathe 12 times a minute. So all the studies have blown this out of the water when it really comes to definitive airway management. Okay, so in standard vent settings of what we came up with, a 480 milliliters and a respiratory rate of 20. And that was for that 80 kilogram patient, coming out that 9,600 milliliters per minute for the minute volume. So that old school method of a tidal volume of 500, respiratory rate of 12, that gives you a minute ventilation of 6,000 milliliters a minute. So a little bit less than what we had. That would be equal to calculating a minute ventilation for a 50 kilo patient and a tidal volume for an 83 kilo patient. And that's based off of numerous researches. That covers the EMS world, in-hospital care, ICU care, respiratory care. This is now the standard. Now that you've got that math done, you know their minute ventilation. So on that vent, you can set their tidal volume, you can set the respiratory rate. Something else you need to consider is how those breaths are going to be delivered. That tidal volume, over what kind of period do you want that tidal volume to be given? Well, the standard is a 1 to 2. That means that tidal volume is given over basically 33% of that respiratory cycle. So for an example here, so if your patient is breathing 20 times a minute, that's a 3-second cycle, because that would be, that happens, 60 divided by 20 is 3, so 3-second cycle. So that would mean that you inhale for 1 second and you exhale for 2 seconds. So let's do another one. 15 breaths a minute, that's a 4-second cycle. 60 divided by 15 is 4. So at that 1 to 2 ratio, that would be inhaling 1 second, exhaling 3. And then the same applies to that 10 breaths. 60 divided by 10 is 6, so that's 6-second cycle. So you're inhaling 2 seconds, exhaling 4 seconds. Where that standard is 1 to 2, 1 to 3, that's your standard I to E ratio. So let's talk about some reasons to deviate from that standard setting of just starting in the middle of 6 milliliters per kilo to start calculating your tidal volume. So in the event of an injured lung, so lungs that are really sensitive, their tissues kind of damaged, such as ARDS, severe pneumonia, some pathophysiological conditions going on to where that lung tissue is prone to inflammation and other injuries. So you're going to want to calculate out that 4 to 6 milliliters per kilogram. So when you do that and keeping that same minute volume, that's going to give you a higher respiratory rate to maintain that same minute ventilation. In the event of an obstruction, so say a patient that's on a vent that has a major COPD exacerbation, major asthma condition, something that is causing bronchoconstriction, a true ventilation problem to where there's issues with the air flowing in and out. You're going to go with a higher tidal volume to keep a lower respiratory rate. And then when you do that with that lower respiratory rate, that's going to allow you to give a higher inspiratory to expiratory ratio. So that normal 1 to 2 or 1 to 3, you're going to go with a 1 to 4 or 1 to 6 on those obstructed patients. So that would mean that you're inhaling in fine, but you're having difficulty exhaling, which is that typical bronchoconstricted patient. They have bronchoconstriction, the air comes in, but then they have air trapping, so it has a hard time getting out. So if you keep that low ratio and you're keeping air going in and you're keeping the vent set to do a 1 to 2 and the air comes in fine but it's going not wanting to get out, the vent's not going to recognize that and it'll do what's called breath stacking, to where if that air, the vent's only set up to let it come out over a 2-second period, or the 66% of that ventilation ratio, where that person really needs a longer period to expire, you're going to start pushing air back in before the patient's fully expired. And that's going to give a bunch of pressure alarms because it's going to increase that inspiratory pressure inside the patient. So that thing will start alarming high pressure, high pressure. So that's why you keep a lower respiratory rate so you can elongate out that expiratory phase. In the event that the patient is acidotic, you're going to want to double that minute volume. And so we know those from pathophys stuff that say that DKA patient, what are they most notable for? Those Kussmaul respirations, deep raspid respirations, and they do that trying to blow off their acid. So with those patients, we need to maintain that higher respiratory rate. So when you double their minute volume, you're going to just be doubling their respiratory rate. So that's going to be keeping them up around 18, or I'm sorry, higher, like in those 30 breaths per minute. So if that normal is 18 to 20, you're going to be looking at 36 to 40 breaths a minute. You're going to keep those acidotic patients at. Now let's just go and talk about some of those vent strategies, still based on that 80 kilo patient we've been working with. So going back, remember that minute ventilation for that 80 kilo patient was 9,600 milliliters per minute, and that gives you a respiratory rate of 20. So in the event that they've got an injured lung, they've got ARDS or something else going on, they've got really sensitive lung tissue, you want to start kind of on the more protective side of that. So you're going to be looking at 320 to 480 milliliters. So that's going to give you a respiratory rate of 20 to 30 in that range. If it's an obstructed patient, you're going with that higher tidal volume. So you're going to be looking at 480 to 640 milliliters. And your respiratory rate, that's going to give you that lower respiratory rate of 15 to 20 to allow you to create that higher inspiratory to expiratory ratio of 1 to 4. Now if that patient's acidotic, they've got some kind of metabolic or respiratory condition that send them into acidosis, that pH less than 7.35, you're going to double that minute ventilation as a compensatory mechanism to keep their respiratory rates high. So that 4, 6, or 8 milliliters per kilogram, depending on what you go with, because you still got to think about if they're acidotic with a lung injury. So that's going to give you tidal volumes of 320, 480, or 640, depending on which setting you go with. And that's going to give you a respiratory rate of 30, 40, or 60. So when you double that minute ventilation, you're just doubling those respiratory rates. A few final things to be considering when setting up your vent is PEEP pressure, that positive end expiratory pressure. So that's allowing pressure to stay inside the lungs to make sure that those alveoli are staying inflated, that you're not having a reduction of intrathoracic pressure, so you can do good volume and gas exchanges. The physiological norm of PEEP is 3 to 5 centimeters of water. So standardly with patients, you're going to want to just set your PEEP at 3 to 5. There was a lot of old studies out where they thought that giving additional PEEP was bad, but with the new vents, all the technology that's out, they still need some PEEP pressure on there, whereas and also some patients may need more PEEP pressure, more pressure going down in. So think about that as the basic fundamental of CPAP. So you're shoving and keeping more pressure down in there to say if that patient has some infiltrates in there such as edema, that CHF is being transported may need that continual higher PEEP pressure set in there to ensure good ventilation and good respirations. So as you can see in the diagram there, going up to a PEEP of about 10 is going to actually increase the alveolar diameter. Suddenly is PEEP going to need to be over that, but again, that's all going to be based off what the sending facilities are going to want it set at. And then with that, you're going to want to consider plateau pressures. Okay, so that plateau pressure is basically the residual pressure that's still in there. So this little snippet comes from the ARDS-net. So ARDS, as we know, is has a high mortality risk. A bunch of patients, a very large proportion of patients who go on a vent end up developing ARDS. So a lot of the research is going towards reducing mortality rates of those ventilated patients who go on to develop ARDS. So you want to keep that plateau pressure, which you can calculate out through the vent, is 25 to 30 centimeters of water. So I know there's a lot of numbers, but if you think about normal vent settings is 35 to 45 for your end tidal, your plateau pressure is going to be 25 to 30. So just kind of in that same range. So if your plateau pressure is above 30, that means that you're basically creating too much pressure inside the body. So you just need to increase that tidal volume by 1 per kilo, just in small steps. So just going to start reducing that tidal volume, but never go below that 4 milliliters per kilo. If your plateau pressure is less than 25, they need more volume. They're not keeping enough pressure built up down in there. If that plateau pressure is less than 30 and you're getting breath stacking or desynchronization of the ventilations, go ahead and increase that ventilatory, your tidal volume in 1 mil increments, but don't go above 8. Now think about stuff, if there's a lot of other conditions that can go into that might alert high pressures. So other stuff that could create those high plateau pressures, a patient could have developed a tension pneumothorax or something in there. So just don't get too focused on the numbers on the vent, but otherwise if you know everything's okay, you want to keep that plateau pressure between 25 and 30. And the last consideration is the Fio2. In the past few years, we've all learned that you can give patients too much oxygen. So we don't want to keep these patients who are on a vent on 100% oxygen. So the Fio2 is just that percentage of oxygen being delivered. Because if we give them too much oxygen, the free radicalization goes on. We don't know if that's 100% exactly what they need based on just what that pulse ox says, or if it's really 200% what they need. And then the free radicalization goes on, and those oxygen molecules are attacking cells, killing tissue. What else can occur is atelectasis. So basically what happens there is, our atmospheric air is 21% oxygen and roughly 79% nitrogen. So if you continually flow the oxygen through there, it's going to wash out the nitrogens in the lungs. It's going to make your lungs essentially become 100% oxygen also. Well, the nitrogen's a pretty thick gas, so when the nitrogen's still staying in our alveoli, it keeps everything inflated. So it also helps create that a sense of PEEP pressure, keeping those alveoli inflated. But if you do the oxygen washout, you get rid of all the nitrogen and causes those alveoli to collapse. So we all know once those alveoli collapse, the patient's not going to get any oxygen. Okay, so another chart that comes from ARDS-net is we generally want to go with kind of a normal pathophys 5 of PEEP, and we want to ensure oxygenation and good ventilation with the lowest Fio2 we can. So you're depending on what the doctors order, which strategy they go with, depending on what condition they got. Now mind you, this is all based on a national document, not just what the protocols are going to be. But for, like, say those ARDS patients, your oxygenation goal from a national scope is 88 to 95%. And you're wanting to maintain a PaO2 of 55 to 80. So that's all based off of blood work. Something we're not analyzing. We're not continually going up the road doing ABGs. So based on what those ABG values are is what your pressure settings are going to be. So depending on what kind of strategy, they may need a bunch of peak pressure and lower FiO2 settings, or they can stay kind of on the lower on the PEEP and give a little bit more FiO2. It's kind of a fine balancing act, just depending on what that patient's pH balance is. Here's a common picture of a pretty common vent that's used, LTV 1200. Several agencies are using this, Air Medical Services. So it just kind of gives you a idea of the basic parameters that you'll go and set. So if you see here, once you figure out your minute ventilation, now you can go and enter in your tidal volume, your respiratory rate, and then in here is where you're going to be seeing that I/E ratio. So when you're calculating that I/E, what you're going to do is here. So if you're in that instance where you're actually going to ventilate them that 10 breaths a minute, and it was, inhale 2, exhale out your 4, you would need to change this to 2. Otherwise, this is what you need to use to set that I/E ratio. This is going to be your FiO2 settings for oxygen. So not all ventilators have this. They may be set up differently using a Venturi to adjust the oxygen coming in, but a lot of the newest ones you're able to actually adjust the FiO2 in here. And then you're going to have your PEEP pressure that you can set down here. That physiological norm is about 3 to 5, but in some instances you may be required to have a higher PEEP. And some of this other stuff, the more defined things here, we get more into that in the face-to-face sessions that we'll do. In conclusion, things that you really need to be considering is the fact that when you get to the hospital, you're not going to be just handed the vent and say set it up. You're going to have orders. But the goal of all this is to apply what you know. So go in, have an idea of what parameters that vent needs to be at to double check and make sure the orders were written out appropriately. If you feel like those orders are not written appropriately, have the conversation with your physician. They're open to discussion. The physicians are busy. They're trying to get them out. Mistakes can happen. So they're open for discussions. Just approach them appropriately and say, hey, I think we need to adjust these settings because of this. So just apply what you know to ensure the best care for your patient.